Ellen. Thanks for joining us today. Today's episode focuses on tackling collective occupational trauma, which refers to what happens in healthcare environments, as well as non-healthcare environments, when we are forced to push through stressful and traumatic daily work experiences, including exposure to hearing or seeing others in pain, fear, and terror. As today's guest will discuss, the COVID-19 pandemic and national civil unrest due to gross inequities of people of color are facing on a day-to-day basis have introduced an even higher level of stress for healthcare providers because we're experiencing what our patients are experiencing on a day-to-day basis. Fear, anxiety, uncertainty, constant worry about health and safety, and loss of loved ones. Our guest today will walk us through what happens during a trauma tsunami, when patient and provider boundaries are muddied, making it difficult to conduct our professional role, take care of our patients, and care for ourselves. And she'll discuss what we can do to mitigate the tsunami. So let me introduce our wonderful guest, Ellen Fink-Samnick, a Doctor of Behavioral Health student at the Cummings Graduate Institute of Behavioral Health Studies. Ellen expects to earn her degree in June of 2023, and she has previous degrees in sociology and a master's degree in social work of clinical practice, and she earned postgraduate certificates in administration and supervision. Ellen serves as a national expert on social determinants of health, currently serving as the chair of the annual RISE Summit on Social Determinants of Health. Ellen's experience with occupational trauma dates to her first job as a social worker in East New York in the mid-1980s, right at the cusp of AIDS and HIV. Ellen's company, EFS Supervision Strategies, offers organizational training, mentoring, and consultation services to empower the interprofessional workforce. And Ellen is a prolific writer, a sought-after speaker for national conferences, and is the recipient of numerous awards, including the National Award of Service Excellence in 2016 from the Case Management Society of America. After our podcast today, we will be providing links to connect with Ellen on LinkedIn, Twitter, and on her blog, Ellen's Ethical Lens. Welcome, Ellen, and thank you so much for taking the time to join us today.
Oh, it is my pleasure to be here, Dr. English. I cannot tell you how excited I am to share the model and strategies, because I think everybody wants to roll up their sleeves, dig in, and go, all right, just tell me what to do.
Yes, we're definitely at that point of, we're all, I think, very beleaguered and fatigued of hearing just how bad the mental health crisis of the COVID pandemic has been. We're hearing every day more and more information about how social isolation leads to a multitude of physical and mental health deficits. And as healthcare workers, we're all really at that point of how can we do this for much longer? So I'm really excited to talk to you today. One of the things I wanted to thank you for sharing with us is the cycle of collective occupational trauma model, which for those of you joining us on video is already up on the screen. And you recently proposed this model to help us understand a little bit more about collective occupational trauma. So for listeners who aren't familiar with the model, could you walk us through the different components, please?
Sure. And, I'll preface, I am a very visual learner. And so when I talk to other health and behavioral health professionals, they're like, Ellen, can you create something that just portrays what we're experiencing? And I sat down at my computer and I started to get creative. And the next thing I knew, here we go. So, we've got this dance that we as the workforce are going through with our patients, clients, members, consumers, the folks that need us. And if you look at the three concentric circles in the middle, they are strategically embedded within each other, with the professionals, unfortunately, being the smaller of the circles. There we are, our entire interprofessional workforce, who has been on the front lines, whether vicariously experiencing the pandemic or directly experiencing the pandemic. Our patients surround us. They are experiencing unforeseen challenges with trauma and their lives, personal and professional, family, friends, and then you've got the population as a whole. Obviously, any model will have a point where all of the energy within it spews out at some point. And so that collective energy comes out in the form of collective induced stress from the top, goes around, and then comes smack into where the professionals' space is. And that is the collective infused trauma that we deal with. And it just keeps going around and around and around in this endless loop. On the left and the right are the stressors, if you will. Some want to refer to them as vulnerabilities. I'm going to call them like they are. They are the stressors, both professionally and personally, that we deal with. And they are massive. And if you look through each list, on the left, it's from deaths of colleagues, illness of colleagues, having to come into work and suddenly be told, tag, you're it, you're going to the emergency department, tag, you're it, you're doing virtual health for the next year. Worries about job security, worries about if the role that you're doing is within the scope of your ability. Can you heed that quadruple aim of the right care at the right cost at the right time, and still embrace the work? And along with that, you've got concerns about occupational safety, the actual protective, the PPE, and just the demands of the workforce. They are massive. And then on the right, well, all the personal issues that we deal with and stressors, from Maslow's hierarchy of food, clothing, and shelter, to worry that whether or not our children will be able to be safe when they return to school. I know I'm doing this interview with you now from Virginia, where many students have returned to school. And I hear this all the time from my colleagues and friends. How safe are they? Will they be able to stay safe within that environment? We know that many colleges are starting to look at mandatory vaccines as a way to bring on-campus life in person back in the fall. We'll see how that plays out. But all of the stressors that people worry about with, will my job continue? Will I be able to pay my mortgage? Who knows whether we'll have eviction moratoriums maintained and prolonged or not? The availability of health care, unemployment is up. These cause stress for the average human being, and thus the model in its form.
Thank you so much. And I'm just grateful for, like you mentioned, the visual to really help kind of understand how all of the different stresses coming from different perspectives culminate in the situation, I would say this boiling pot of water that we're all in right now. One of the things that I think is hard sometimes for patients to understand is that when the professional is experiencing the same stress that the patient is, we're often as healthcare providers told in very stressful and many times traumatic situations. We have some training in what you've referred to in previous conversations as process and roll. However, how long can we do that on a day-to-day basis during a global pandemic when all of these personal and professional vulnerabilities and stressors are, sort of the walls of that compacting situation that we're in, when those walls are closing in around us? And, personally, one of the stresses that I have experienced during the pandemic was I got to a place where I couldn't continue to do two jobs anymore. One as the CEO of Cummings Graduate Institute and, be innovative and entrepreneurial and really think about the vision of where we needed to go in education and training of integrated care, workforce, as well as clinically see patients from a doctor of behavioral health perspective, which also always involves a degree of providing behavioral health and stress support to the healthcare team that you're embedded upon. And so, just having experienced that personally, having experienced it professionally, I can definitely really, the model really resonates with me. So I'm wondering if you can talk a little bit about, the difference between what healthcare providers and patients were experiencing prior to the pandemic, and maybe say a little bit about how the pandemic has specifically maybe impacted our understanding of trauma.
Well, you used some of my favorite terminology that, excuse me, I think a colleague heard me say maybe 20 years ago. It's like, because I worked in the emergency department, I worked in intensive care units of hospitals, and it was the sicker, the messier, the more complex, the better. But don't ask me if I stopped and took lunch, if I stopped and took a break, because that's just not how we did it. We process and roll. That's how you do it in acute care environments. One of the articles that I recently saw used some very wise words about feeling brain fog. If
Yes.
you are, you're not alone. And what that was about was we're all really good at managing stress in the moment, even for the short term. And even with all my joking about processing and rolling, sure, that might be the way you do your job for the week or for the month. Then you take a day off, you go get a massage, you go get a manicure or pedicure, you take a day away with or maybe without your family, something to debrief. You spend some time with friends, you go out to dinner, you get drinks. Everything has changed. Everything has been upended from that. So all of the prior strategies that we engaged to move through and cope with those stressful times and re-energize us to continue to process and roll, those went out the window. And it was as if the workforce was suddenly going through ongoing, repeated trauma to the point that they've been experiencing PTSD. And so, yes, are you experiencing brain fog? Yeah, because you're on overload.
Yeah.
And we know everybody's used to dealing with stress. My goodness, I started this wonderful doctoral program a year and a half ago, and yeah, that's been stressful. But that's a good stress for me. And then there's, tougher stress with worrying, oh, well, will my client base continue? And how do I need to shift my income to be able to continue to do all the things I want to do? And, take 2 months off to write a book and continue my studies. So it's constantly shifting and looking at what do we need to do differently? That takes different types of energy. The pandemic is not the same one and done as, let's say, a mass trauma episode or a disaster episode. And having worked on 9/11 at the hospital closest to the Pentagon, yes, for a few months we were all dealing with the fierce emotional attack or assault, if you will, and trying to process and roll, but stop and recharge, and process and roll and stop and recharge. But then we went back to a new normal.
Right.
A year ago, we were told, and I say we, the collective society was informed, well, hopefully this wouldn't be more than a few months. And then a few months turned into 6 months. And then 6 months turned into layoffs and furloughs for at least 40 to 50% of the workforce, many of them members of the health and behavioral health workforce. And then 6 months turned into 8 or 10 months. And here we are now, a year later, with virus variants and ongoing concerns about efficacy of the vaccine, and everyone wondering, well, we've started to get back to normal, but yet numbers are still escalating. And I know in my own region, and the numbers I saw the other day said they are up as much as 50 to 60% in some states.
Yeah.
So we're still going through this. We're still experiencing this ongoing level of not only stress, not only basic trauma of severe assault on our systems, but a vicarious experience that is actually shared. It is collective, and that's where the language of this model came from. Very specific. Yes, we're sharing the trauma with our patients and our colleagues and our family members and the person who owns the local store, or maybe the local dry cleaner, or our local market. But this is a collective occupational trauma that our health and behavioral health workforce is experiencing, and is also prompting a new cultural mindset for healthcare leadership and organizations. They need to look at different ways to manage these stresses so that the workforce can get out the other side, develop new coping and new practice patterns, and then ultimately be sustainable. So that's a big answer, I know, to your question.
But I think, thank you, Ellen, because, one of the things that I don't think we anticipated, and it's always the unexpected, like you mentioned, if you're entering a doctoral program intentionally, that your free time's going to go down, your stress and busyness is going to go up, you're going to be working nights and weekends. That was a choice, something you anticipated some additional stresses, but with a pandemic, no one anticipated really any of the challenges that we would be facing. Certainly some individuals who had taken a personal interest in prepping may have been ready for the initial, having a month or 3 months of supply of food or water to hand at home. But they also were not prepared to think about what happens if we all lose our jobs at a rate of 40 to 50%, the workforce loss, or, as an Uber driver or a restaurant worker or a bartender as a second job, if I lose my second source of income and I only have my first source of income, how does our family make it by? And then what happens if I lose that primary source of income as well? And then what if I get sick on top of it all? What if I have a small team, each member of which is critical to daily operations, and 3 out of the 10 people that I lean on every day for getting business done get sick at the same time, or has a family member who gets sick and they need to drop everything and go, or are hospitalized for a long period of time, or they never return. All of those unanticipated traumas, like you mentioned, are, those traumas being unpredictable. And then in addition to that, not having an end in sight. So prolonging that level of uncertainty and stress, we know that leads to the brain fog. We know that it leads to burnout. And when we're dealing with it and our patients are dealing with it together, I think it really has proven to us that our own capabilities of process and role are far lower than what we have been able to do when we deal with a massive trauma like 9/11, that, after a few months, we can be getting back to a new level of normal. So thank you. Yeah, I think from the pandemic, we've definitely dealt with something that no one could have necessarily predicted exactly the way that it's played out. And also, I don't think anything could have really prepared us for this, year in time. But another thing I wanted to talk with you a little bit about was, coping. So from a patient population, of course, and those of us who have been in behavioral health care for a long time would and have been since the beginning of the pandemic, recommending mental health counseling. But what happens and what the data has told us is that mental health, the availability and access to mental health counseling has not been a match for the population health need, particularly for the healthcare workforce. So I wanted to kind of talk about that because, you mentioned the trauma tsunami. And I wanted you to talk a little bit more, if you could, about what that means and where you came up with that terminology, because I think it's perfect.
So I'm honest, I can't claim that one, and it was appeared in one of the million or so articles that I came across.
Sure.
But I saw that term and I went, yes, that's it. And people have said, well, is this the client population? Is this the addiction population? Is this severe mental illness? It's like, no, this is everyone.
Everyone.
And everyone is dealing in one way or another with their own mental health exacerbation, whether they want to admit it or not. The workforce itself, our workforce itself, for years, I have said it is the biggest occupational hazard in the world that health and behavioral health professionals take care of everyone else before, if not instead of themselves. Boom.
Mm-hmm.
That is, I think I said that first in 2006. So here we are now in 2021.
Mm-hmm.
Never imagining what does that mean when we have a time where an industry so reliant on templates and flowcharts and graphics and figures and policies and procedures is suddenly forced to function without a playbook.
Right.
And I mentioned 9/11 before because it's still, to me, is the closest thing that I've experienced to this time, where I can remember standing in the stairwell of the hospital with a colleague who I valued, I respected. At that point in time, she was the one with 40 years of experience in the industry, and having to slap her across the face because I could not physically move her.
Wow.
From the point she was at.
She was really in that fight, flight, freeze moment.
Very much so. And there were, we had our disaster plan in place and people were trying to go to those spaces, but nothing prepared us for the influx. We were 5 miles from the Pentagon, and so you could smell the fuel. We were expecting every patient. We ended up getting everyone from the community coming by, people that were having chest pain, heart attack, panic attacks, people looking for family members and friends that were working in the Pentagon. And then the victims who did come in, some of them burned, 2nd and 3rd degree burns that only wanted to go back to the E-ring or what they thought might be left of it to find their colleagues. Right. And so we're all dealing with that on that day, and no one was ready for it. And yes, we processed, enrolled, and we got through it as a workforce, but they had brought in several crisis organizations to help us through. And what was sad was, first couple of days, people went afterwards. A week after, they did a return because they were doing their critical incident debriefing for the team. 2 weeks later, the space in the auditorium was there were a lot less people there. Yeah. And I think by that last week, in the last month, I was one of 5 people, and I went up to them to thank them for being there. And they said, we know you're a clinical social worker by training. What do you think has gone on? I said, they're already getting ready for the next thing. Yeah. They're not going to stop and deal with their mental health. And we also have to remember that health and behavioral health professionals admitting to vulnerability from their own mental health, big stigma. Yeah. And we've seen the literature for that across social work, psychology, nursing, medicine. The last thing you want to do is admit that you have some shortcoming, that you are feeling that your boundaries have holes like, melted Swiss cheese. Right. Because then what does that mean down the road for your ability to manage the rigors of the job? Yeah. The rigors of the job are the reality, and I don't know.
So when the rigors of the job and the reality of the job match, and I think it is, being a healthcare worker, including mental health care worker, is very similar to being a firefighter or a paramedic. because from a certain extent, when you express that you're experiencing a hard time because of the stress of the work, there are many still out there, both in and out of the healthcare profession or mental health care profession, who would say, well, what did you expect? What did you think you were getting into? This is just part of the job. So aren't you trained to deal with this? And the reality is, no, we're trained to be helpers. We're trained to be maybe paramedics or rescuers, to get others out of danger. Like you said, it's the others that we're oriented to. And we put ourselves last by training and also by choice, because that's how we view our mission, our personal and professional mission in life. So when we're dealing with this trauma tsunami, and the population and all of our patients are dealing with the same thing that we ourselves are dealing with, and there's a lack of those crisis organizations that come in and help, because what do you do during a global pandemic? It's not the same as a tsunami in Haiti. It's not the same as a hurricane in New Orleans. It's not the same as a hurricane in Houston. We don't have the kind of rescue organizations or crisis relief organizations that can address a global pandemic and the help that healthcare providers need. So it's kind of on, and I've noticed in the past year, there have been a lot of webinars and a lot of professional development related to how are we dealing with the pandemic. And the truth is, the population is still looking to us for that answer. Right. And will always look to us for that answer. So I ask myself often, what happens when we are too brain fogged to be able to see beyond the next patient, the next 8-hour shift, the next 12-hour shift, the next week, and there's no vacation time, and I'm picking up extra shifts because I'm not sure when the next time my mortgage needs to get paid, if we're going to be able to pay the whole thing. So
right. Exactly.
So yeah, I appreciate your thoughts on it. I'm also wondering, because of your expertise in the area of social determinants of health, what share, and I've looked at a lot of the data and I'm familiar with it, but I know many of our listeners or, those who are watching along with us today may not be familiar with what have we learned from a social determinants of health standpoint throughout the pandemic.
Well, the one thing people have said long about the social determinants of health, they are not new. They're just newly scrutinized. Yep. They have been with us since, the Middle Ages. Before social workers are trained in social.
What we call them might have changed, but the fact that they're there hasn't.
Well, and anyone that has seen Monty Python movies, I mean, we could start to go through the list of movies that frankly show haves and have-nots. Mm-hmm. Mm-hmm. That's what we're looking at. We're looking at the social determinants of health. But in 2012, when CMS said, hospitals are going to be penalized for readmissions, right, we found that 50% of readmissions within 30 days of discharge were caused by people not having those necessary psychosocial resources to keep them healthy and promote their wellness. Boom. The social determinants of health, which Sir Michael Marmot named in the 80s, 90s, suddenly became the greatest thing since sliced bread. Mm-hmm. And the number one thing on every organization's list. So that was pre-pandemic. Yeah. Pre-pandemic, we knew it was $3.6 trillion in national health expenditures that were being spent primarily because of exacerbation of chronic illness, lack of primary care, lack of integrated care, lack of mental health parity, despite the law being put in place in 2008. Yeah. So lots of access to care issues that continue to be a challenge for populations that had less than more. Mm-hmm. Mm-hmm. Then the pandemic came. And when you look at things like, the CDC, I'm a big fan of just about anything they put up, and certainly they continue to update, for example, information on ACEs in looking at the impact of trauma, because we know trauma associated with advanced childhood experiences and growing up witnessing abuse, neglect, child abuse, adult abuse, alcoholism, substance abuse,
Incarceration of a parent.
right, and sudden loss or death of a parent, abandonment, and challenges with attachment issues.
Mm-hmm.
But we haven't looked at trauma in the context of sudden onset of illness, death of family members close to us, suddenly being healthy one minute and not healthy the next, the impact of that trauma on exacerbation of chronic diseases, of autoimmune disorders, of mental health issues, whether previously dealt with issues or new ones.
Right.
So, we're seeing now this flurry, this tsunami of data associated with women of color, populations of color, the BIPOC community, the Latinx community that were so greatly affected by morbidity and mortality of COVID transmission, suddenly now also having all of their public health wounds and needs literally on display because they have even less. I mentioned the eviction moratoriums and the fact that yet again we're waiting for those to be extended for some over 40 million people that are unemployed, both 26 million unemployed by virtue of many factors, and then the other 14 or 15 million unemployed because of the pandemic.
Right.
We have physical and behavioral health still a grand challenge. I think I saw right now COVID is the number 3 cause of death. Well, what does that mean in communities that are more vulnerable and disenfranchised, that are already predisposed to chronic illness and now are more so? What does it mean for communities that may have persons that may have less than a few thousand in the bank and suddenly are worried that they're not able to pay their mortgage, their rent, their lease, they're going to end up on the street in a shelter, they can't afford medication, they can't afford Wi-Fi. I always laugh when I hear, oh, well, we got virtual health. That's great, we have virtual health. Does everyone have the same level of access? And we joke that right before, people don't know this, right before we started, there was like a little blip of the internet. And I have excellent internet, so I can't, and broadband. So I can't imagine what is it like for communities where broadband is an issue, where Wi-Fi access is an issue, where being able to afford the latest digital and mobile devices that can actually connect with those platforms. And many people are doing mental health via telephone. Without any visual access, which is not conducive to anything of a quality nature in terms of care.
Well, and even, those with access to a smartphone may not have the technical ability to figure out, for example, how to get an appointment for a COVID vaccine. That's been happening quite often in my family. For my grandmother, who's 92, she's never had anything more than a flip phone as far as a cell phone is concerned. And so, I would have been able to had my mom and my uncle not been able to team up and get online and spend hours trying to get her an appointment. And then in addition to that, they had to drive an hour and 15 minutes to the nearest COVID vaccine pod. And, they would have taken any time that they were able to, but a lot of the times that they had available were either in the middle of the night or, at 4 o'clock in the morning. So they were delayed in getting an appointment due to that. So I'm looking at, just the differentiation between being able to get access to care from a technical perspective, even if we have telemedicine options and virtual options. I know that there are still plenty of adults over the age of 65 in the United States who haven't had access to a COVID vaccine just because they have no one to help them get that appointment. And, the requirement for having Wi-Fi access and the ability to technically navigate a very confusing, difficult process of getting an appointment for that vaccine is going to keep us below the line of our goal for getting the population vaccinated.
Correct.
So it's
yeah. I was just on top of that. Then you have issues around health literacy,
absolutely,
and trust, which again, before COVID was a challenge for many communities. And I often say, in the context of the social determinants of health, communities stop and take care of their own. That's what we're seeing at this point as well, with churches and local community and senior centers stepping up to try to educate and go door to door to educate the people who reside in that community about the vaccine, about public health issues, about being able to trust that this is a good thing and will keep them safe.
right.
Because, and there was a great article in NPR about this is far more than Tuskegee in the context of the Black community and trust and of health literacy and treatment. But we're dealing with public health as racism, and racism is public health. The two are going hand in hand.
Absolutely.
And need to be addressed to have a truly effective population health effort that accounts for holistic health equity and assures attention to all the social determinants of health and mental health, all of those issues that impact access to care, detract from access to care, obstruct access to care, including trust of the health and behavioral health system, including promoting availability of concordant care across populations so that people feel like the professional you're talking to won't dismiss your symptoms because of your gender or the color of your skin, your sexual orientation. I mean, all of these factors, and I know I'm talking about a lot at once, but I'm being intentional because they all intersect with each other and have created this social determinants of health and mental health intersection with COVID that has prompted far more deaths and ongoing transmission challenges that need to be mitigated.
Absolutely. Absolutely. And I've had some conversations recently with both personal and professional individuals in my life about how, from a 80,000 foot view, I can be grateful for the spotlight that COVID has given us on the social determinants of health and mental health, inequities, healthcare instituted and systematic racism that we are now talking about on a day-to-day basis, that we now see covered in mainstream media, that isn't just a sideshow or something that communities of color had to bring up and be judged for or, dismissed by the larger system in the past. And I have to believe that, when something is valued and measured, that's when things begin to change.
Yeah.
So I have to have some faith in, the vast majority of healthcare providers and supporting voters in the community who are really advocating and, showing up as allies to say, we've been talking about this for generations. We don't see any massive movement in the direction of solutions. And we're all in this together, and we all must advocate and point in the direction that we want to go and work together to get there. So there has been, from my experience and from what I'm seeing, at least some hope, shining in that forward future direction. So,
and I would agree with that. I think, when you see the American Public Health Association saying, yes, racism is a public health emergency and crisis. And I know I've said it before, we can't say it enough. And we've got over 35 states that have declared it, racism, as a public health crisis, and close to 1,000 counties that have declared it as a public health crisis. You can go to the American Public Health Association website, and it brings up all the states, brings up all the counties, it brings up all the initiatives in play. You can look at sites like county health rankings and roadmaps and look at what their social determinants of health and mental health are. We have the data. We know what the issues are. What COVID has done is said the nation can barely survive a health emergency of this type. And certainly those who are daily at risk of the social determinants of health and mental health, they're barely surviving it. And we've got more have-nots now than haves, because you have people that have lost their jobs and become more vulnerable. We're going to start to see more terminology, more emphasis on housing insecurity. The latest term I saw today was nutrition security. Yeah. It was a great article in Journal of American Medicine. Instead of food insecurity, at the end of the day, we have to be mindful of, some people don't even know that they're hungry.
Right. Some people don't know that the food bank food, which might keep you fed, may be shortening your lifespan. So I've worked at food banks many years over lots of different kinds of jobs in the behavioral health sector, and after the first nutrition class I ever took, I went, we've got to throw out 90% of what's on the shelves in here, because it's killing our patients. And I can't in good conscience hand this box over to a family knowing the salt level in the canned foods and the health literacy level of, the people that I'm giving this to. We've got to find, some other strategies here. So like I said, I do feel hopeful, but I think ultimately it boils down to the world is looking at healthcare providers, healthcare organizations, national professional organizations such as the American Medical Association and, the American Academy of Family Practitioners, et cetera, to provide the guidelines. So at the same time, we have to get beyond the model here of collective occupational trauma so that we can keep care of ourselves, at least at the forefront, so that we can continue to care for others. So tell me a little bit about, on a day-to-day basis, what are some ways that we can, instead of, going to get that massage or maybe going to get that mani-pedi that maybe isn't accessible even or even safe for us at this point, what are some micro doses of self-care that we can be shifting our perspective to do so that we can keep ourselves out of brain fog and really be able to focus and lead?
Right. And I think, there are a series of things. Certainly, I don't want to dismiss the efforts that organizations have put in place to emphasize the availability of mental health and behavioral health through their employee assistance programs. But let's go back, because sometimes people feel like, oh, well, are you saying I need to go to therapy? Well, you may need that. But let's go back to look at what you can first do to get past this a little bit. And I'm going to refer to some notes because there's so much, but I want to keep it focused a little bit. And the first thing I often tell people is you got to stop and recognize everybody's crispy around the edges right now.
Right.
And it's okay. It's really okay.
Yeah.
It's okay to be angry. It's okay to be frustrated. It's okay to feel sad. It's okay to not know how you feel. It's not okay to not do something about it.
Right.
The most negatives you'll ever hear me say in one sentence.
Yeah.
But we have to be mindful of it. And the first thing I often tell people to do is just stop and take 10. It might be 10 seconds to just take that deep breath, to look out and go, wow, it's sunny out. I need a little vitamin D.
Exactly.
Might be 10 minutes because you've had a rough interaction with a patient, a client, a colleague, a family member, and it's back to your corner, 10 minutes to just stop. You
Mhm.
can afford to stop. It might be 10 hours. You're going, you know what? I think I need a day off. Well, I don't know what to do. Well, you know what? I love the articles that say, here's what you can do. You can take a drive. You can go look at flowers. You can, my favorite thing is to just get in my car and blare the music. Some people like to do a dance party.
Mhm.
And it doesn't matter whether anyone's watching or not. And if my cats could talk, they'd say all sorts of things. But 10 hours just to give yourself permission
Yeah.
to do something. Now, be careful about sleeping too much, and
Right.
we'll talk about sleep in a minute. If it might be 10 days, well, you know what? You need a real vacation. You
Mhm.
need time off. And I just saw something earlier that people should feel comfortable that if they wear masks and they've been vaccinated, they can fly places. They
Yes.
can feel comfortable to get out. And I'm hearing a lot of people doing Airbnbs. And again, the typical disclaimer, I'm only mentioning these products, if you will, for the purpose of example, not for endorsement, but
Right.
just to be able for people to get out and have a change of pace from
Right.
what they're doing. I have some friends that are going to the beach. I have some friends saying, you know what, we were both struggling with employment. We can't do everything, but we can't really get away. But every day we're going to try to wander around and do something different just to get out of this house. You
Mhm.
start to get to 10 weeks or 10 months, then you need a little extra guidance. That's when, okay, does your employer have an EAP program?
Right.
They'll provide often 5, 10, some have even expanded those visits to a more longer term or a brief treatment intervention. There are a lot of also online therapy. There's one of my favorite is the Emotional PPE Project,
Right.
which they were set up. It's a twofold, almost two buckets. One is for um, information about what professionals can do to be able to take care of themselves and support themselves. The other is for licensed mental health professionals to sign up and provide pro bono counseling to
Right.
those members of the workforce that might need it. So we're starting to see a lot more of those sorts of resources available that people can feel a higher level of confidence in seeking mental health. The
Right.
other thing is, people spend a lot of time these days online. I think we've gotten used to that as an escape. Unfortunately, we can find ourselves doom scrolling,
Absolutely.
and that becomes toxic.
Mhm.
It's energy draining versus energy replenishing, and you got to be able to recharge. You got to be able, you can do some walking, you could do jogging, you got to get those endorphins moving.
Mhm.
Tai Chi, Pilates, some people are getting into different types of yoga and relaxation strategies.
Mhm.
People have forgotten they can still get together
Yeah.
with friends and colleagues. They can do it virtually. I know people that do virtual happy hours. They go to movies virtually.
Mhm.
They make a point to talk about non-COVID related
Right.
things like the newest pets they adopted, or food that they took out, or they share music with each other and they
Yeah.
kind of do concerts, quote unquote. It's really been pretty creative. They do cooking parties. I am not the chef person.
Mhm.
I like to. I just, honest, don't have the patience or don't make it a priority. But I know a lot of people that have really gotten into cooking and rediscovering cooking and baking recipes. And then we have sleep hygiene. Then we come to the importance of getting rest.
Mhm.
One of the things I've heard from a lot of people is, oh, well, they're taking a lot of naps because they're working at home.
Mhm.
Don't do that. It's probably amongst the worst things you can do for yourself. What you're better off is to get on a solid schedule with less naps where you then get a decent night's sleep.
Better quality of
Because
sleep at night.
definitely better quality of sleep at night, and avoiding stimulants at bedtime, whether they're food stimulants, whether they're dialogue stimulants. It may be the only time that you have to talk with your partner about life and money and things like that. But I know the other night I said to my other half, no, we're not going to talk about, the bank account. We're not going to talk about this work now. No, that's not where I need my energy going, because then I'll be up all night.
Right.
So we can make a date to talk about that, but we're not going to talk about it now.
And I've seen that, with many of the individuals as well as healthcare professionals and couples, just having a really hard time viewing their own agency in deciding what they will and won't engage in during the day, whether it's screen time or, good quality sleep hygiene, good quality nutrition, drinking enough water, taking a break during the day, like you mentioned. Oh, it's sunny outside. I'm going to go out and just take a walk around the block while it's sunny, and then come back and grab my next patient. And, this kind of leads me to the idea that if we can find a way to be a little less toxic with our own mental health and our own self-talk, and a little bit more supportive, not just of others doing these kinds of things, but start to think about how, if we embrace some of these good self-care practices or microdoses of self-care throughout the day, and we're performing them in the span of a healthcare day, that is contagious. Other people say, oh, I wish I could do that, or must be nice. And then you say, well, you're welcome to join me.
And it gets modeled and mentored for everything. I know we've
modeling and mentoring are absolutely two. I think we have gone in the direction. I think we've gone away from good quality mentoring in healthcare because of time, and the healthcare dollar is always short when it comes to being a better workplace for healthcare providers. But it's the modeling of poor behavioral health that I think has been so contagious amongst healthcare providers for so long, that it has really created toxic work environments from a healthcare perspective. Yeah. So I wanted to ask about that too. What are some of the toxic employment culture responses that you've observed over the years? I have lots of what I've observed, but that can really shut down self-care, for an employee who's really trying to make some changes in the direction of health. And kind of talk about what those are, and, maybe what we can do in those situations if we are that employee who's trying to do something in the direction of self-care, but we're getting shut down by someone we view as a mentor or a colleague.
Yeah. And I think, so number one, how long we got, because this is a very big topic.
Yeah.
And it's one I've been approached with many times over the last few months, particularly by leadership in organizations, whether they're nursing leadership, physicians, case management leadership, which could be any one of several professional disciplines, all wondering, okay, what do we do?
Right.
And it's hard to say to them, well, it's not that simple to suddenly shift the way you've been doing things, where you talk at your employees, presume that they're just going to go and do their job, to a mindset of checking in with them, talking to them. Oh, gee, Cara, wow, you're going a little slower today. Mm-hmm. What can I do to support you? Over the last couple of years, there's been a lot of emphasis on different leadership models, right? Mm-hmm. We've heard about authentic leadership and transformational leadership and inclusive leadership, but especially servant leadership. Yeah. This is a time when servant leaders are absolutely rocking this, and maybe that's an overstatement, if you will. But when you look at any of the work by the Hastings Center, which I'm a big fan of, they put out this model of ethical leadership amid COVID, which is really about recognizing what your workforce is going through, how to keep them safe, that leaders have a mandatory responsibility to their staff to make sure they're safe and nurture them, provide them direction and guidance. But again, it's that process and role mindset. Do as I say. We're here to save lives. We're here to assure that every patient, every client, every member gets seen. Mm-hmm. Without the reality that some people are dealing with more deaths in a single day, maybe even a week, than they ever thought they would have to deal with in their entire career.
Right.
Just saying that is traumatizing. So that means shifting and working with leaders to get them to almost a trauma-informed culture. That's for not only their patients, which is a big deal right now, but also for the staff working with them.
Right.
Prioritizing the safety, health, and well-being of your staff, which every leader does. There is not a leader that I know that doesn't prioritize the safety, health, and well-being of their staff across every practice setting. But how do they demonstrate that caring and the intentionality of that caring every day? Everything from going around and really demonstrating the servant leadership mindset, standing up, rolling up the sleeves, going up to the staff member that looks crispy around the edges, and not only saying, how are you? What can I do for you? I'm a big fan of New Amsterdam. It takes place at what was the real Bellevue Hospital in New York. I was at Queens Hospital Center down the block, over the bridge, another part of the Health and Hospitals Corporation in New York. Mm-hmm. And Max Goodwin, or Dr. Mannheimer in real life, was all about, what do you need now? Mm-hmm. What can I do for you right now?
Right.
That's servant leadership at its best.
Right.
That's going up to your staff member and saying, okay, I get it. You're overwhelmed. I hear you. Strategizing is not what they need maybe in the moment. This is about crisis intervention. So sometimes, not all the time, you can cue them, but other times it's, all right, how about you take care of the 5 discharges you have? I'll do all your admissions. Mm-hmm. If I were to talk to all of the people working in hospitals that I know as colleagues, I would say probably less than 50% of them would say they had a leader that would do that. Now, how many would want a leader to do that? Oh, probably all of them.
Right.
But we need to see more of that. We need to see more checking in on the staff. Even a lot of people are working remotely.
Right.
Well, you have a morning huddle and cameras on. I don't care if you're in your pajamas. I don't care if you have no makeup on. I don't care if you got a cat in the lap, but something where you can see your staff, because otherwise you don't have a sense of what's going on with them.
Right. And I think authenticity is a huge part of that, because so many times I've heard from people, yeah, my leadership checks in, but it's like they're checking a box instead of, I feel that I have a trusting bidirectional relationship of care with the leader that I happen to be, supervised by, or the person I report to. And I know that if I need a mental health day, or if my mother is sick with COVID and I need to, drop everything and go to the hospital or whatever it is, that I won't be in a position of worry for my job, or, I know that I can be a human being who is employed in this role, rather than employment from a almost like a indentured servitude, standpoint.
Is it a leader that's going to come around and, kind of quote unquote do rounds if you're physically in the space, or is it the leader that will do rounds and then stop? You sit down, look at you eye to eye and say, wow, when I came by last week, you were in the same space. tell me what's going on.
Mhm.
And you know what? Make an appointment with my office, come by, and we'll figure out a plan together.
Mhm.
One of the things I'm hearing from organizations and from leaders is they're getting lots of great feedback from their staff because they're asking, what can we do differently to support you? And guess what?
Right.
Staff is feeling more comfortable to tell them.
Right.
That's
And
also a
and
shift.
organizations can't improve without that information. It would be like, trying to build a community improvement project without any input from the community members. You can
Correct.
build the best thing in the world and no one will show up if you don't have their voice at the table telling you what they value and what they want.
And that's about communication. It's about knowing that the communication is authentic.
Mhm.
There's another article, and I feel like I read everything. I just sleep with whatever literature under my pillow I can. But it was something I saw in Harvard Business Review that talked about how leadership is prone to tell staff to do tasks, especially amid emergencies and disasters, but not explain why. But once we explain why, it gives people a greater sense of control. Even if part of that why is you're admitting together,
Right.
you know what? I don't know what I'm doing here.
Right.
I've never been through a pandemic.
Right.
But you know what? We're going
As
to
we
get
go,
through.
we're flying the plane while we're still building it, and that's just where we're at. No one is doing well as well as they would like to be doing right now, and that's okay because we're trying to do better together. It's not on you alone.
And no one has infinite energy either, right? Nobody is that flawless. No one can process and roll indefinitely. Because yes, we're in that in adrenaline rush, if you will, amid the crisis.
Right.
But this crisis started at the end of February of 2020, and here we are now, April 2nd, when we're recording this, 2021, with some states now at a point where they're back in what they're calling a fourth wave. I don't know. You ask some people, it's one big long wave.
Right.
But we're still going through it.
Right.
And the workforce is worn and tired and needs as much support from their leaders, who also need support from their leaders.
I was just going to go there next, Ellen. I was going to say, I think, an important thing for us also to talk about is that leaders need support from one another. They need their own, leaders need to feel like they have belief and faith in their ability to lead from the individuals that they're, supervising or managing or working with. And they also need their own ability to fall apart, because this is a hard job for a leader too, that, we don't necessarily know all of the answers. We're also building the plane while we fly it. And we have people who we're trying to keep safe and alive, as well as mentally healthy. And then all of the patient population that we care for, safe and healthy and alive. And so I think, from a leadership standpoint, making sure that we're building our own tribes of, comfort and support and the ability to just be authentically vulnerable, fall apart, get the support we need so that we can go back and roll on to the next team meeting or the next day, or, and we get crispy around the edges as well with having feedback, from our teams sometimes that feels as if the team feels we're responsible for it all ourselves, or, from a leadership standpoint, you should know this. We don't know that. We're all human together.
And we were human
asking for that input. And so I think, both from a, team managers or team leads need to be looking for what they can be doing to support the team. Leaders also need that bidirectional support from the team, and they also need that, maybe parallel level support from leadership and management, or leadership above them as well.
And leaders also need to be able and comfortable to say to each other and their staff, you know what, here are the resources for the EAP program. You know what, I've used them too. We need to get rid of that stigma. Mental health cannot be a dirty word for our workforce, nor should it be.
And I think that's one of the other beauties of the pandemic from my perspective is that it's really given all of us kind of a green light to be talking about how stress impacts us. How we feel maybe depressed, how we feel anxious, how we feel lonely, how we feel isolated, how we're bored, how we're, feeling like there's no end in sight, how we're burned out. And I hope that if any, for those in our audience who are listening, that you can take this from both a self perspective as well as a team perspective, as well as a leadership perspective, that this pretty much gives you the green light to say, not only can I talk about it, but when I take steps to address it, going back to that modeling good behavioral health, I might inspire someone else or invite someone else to take those steps with me that might not have gone there had I not modeled that.
Absolutely. Absolutely. And the days of saying, yes, we're helping professionals. That's, legally and in the literature, physicians, nurses, social workers, all behavioral health professionals, we're helping professionals.
Right.
But helping doesn't mean we're helpless. And we need to shift that cultural mindset as well. I can remember the first question I was asked in social work school a million years ago, which is still the first question we ask new psychology students, new social workers, new nurses. Why are you going into the field? And by far, 99 and 9/10% of people respond the same thing: to help people. Oh, goody. And not to be disrespectful to any of my mentors or educators or those out there that really view this work we do as a calling. It is a calling, but it should never be at the expense of ourselves. And the more we use and use and use, there's nothing left. If we cannot attend to our own human condition and be aware of what we're experiencing and feeling, we are useless to someone else's human condition.
Right, right. I love that. Helping doesn't mean we are helpless.
We have to shift that mindset and start to look at, we empower, we partner, we collaborate, we facilitate, we work with our patients, clients, members, consumers, we partner with our leadership, we create interprofessional teams that dialogue respectfully with each other. Yes, in the middle of a crisis, everybody does talk to get a job done, but then you come together.
Right. Well, and I think about it from the perspective of anytime that a patient has ever told me, yeah, I went to my doctor told me I needed to lose weight, and my doctor is 30 pounds heavier than I am, and looks like, he told me I needed to start exercising. It looks like the last time he exercised was in 1983. We really can't make recommendations that we aren't willing to model ourselves. It comes off as inauthentic. And if I can't do it, how do I expect my patient to do it? And that goes for team managers and team leaders as well. If you can, practice what you preach, those actions say a lot more than the words or the encouragement, the recommendations that you give. And ultimately modeling is really, if we can inspire somebody by what we do, not by what we say necessarily, I think it goes a little bit further.
Exactly.
Well, Ellen, thank you so much for your time today. I know you're a busy woman, and I can't thank you enough for making time in your schedule to talk to me about this. Your model is really helpful from a visual standpoint and also from an informational standpoint. So I'd love to share it with listeners. If you're willing, I will include it in the links. And I'm sure we have many more opportunities to talk more about many other topics in the future. So this hopefully won't be the last time that you will be a guest on our podcast.
Thank you for the invitation. Thank you for the highlight of the model and giving me so much bandwidth to talk about something that I've been passionate about my whole career. And unfortunately, the pandemic has only heightened that because the workforce is far too valuable to all those who need it.
Absolutely. Well, like I said, let's keep our hope, present as we look to and point to where we want to get to.
Absolutely.
All right. Well, thank you so much. And for those of you listening, thank you so much for joining us today. I appreciate it, and we'll talk to you next time.